Great. So it's 7 o'clock, so we'll make a start. If I could just remind everyone to put questions in the chat or wait till the end of the talks, then that would be perfect. And what we're doing today is a little bit different. So we're doing a carousel of different specialties, and we'll explain more in a minute. We've had technical difficulties with one of the pre-recorded lectures, but that will be available after tonight's teaching session. So I will hand over to lovely Mrs. de Graaf. I think you're just muted.
It's my great pleasure to introduce Dr. Arel. Roseanne Arel is a consultant psychiatrist based in Cardiff with extensive clinical experience in the assessment and management of mental health conditions. And alongside her clinical work, she has a strong interest in education and multidisciplinary working, as evidenced by her willingness to kindly come and speak to us today. And she'll be talking to us today about the very significant interplay between her specialty and ours, psychiatry and ENT. So Dr. Arel, I'd love to give you the floor. Thank you for your time.
Thank you, Mr. Graaf, and thank you, Emma, for inviting me to speak today. I'm a consultant forensic psychiatrist, but I've worked extensively in a number of different psychiatric fields. And I'm just going to share my screen now. What can you see?
So it's currently just in the kind of open format for PowerPoint, not in presenter view yet.
Right. Apologies, I will stop sharing that screen.
While Dr. Arel is pulling up her presentation, we'll take questions for each talk at the end. So because this is the only live talk, Dr. Arel will field questions at the end of her talk. That's perfect. We can see it now in presenter view.
Okay, fab. So if I flip back and forth, you're seeing the change in screen. Fabulous. All right. So as I say, thank you so much for having me this evening. I'm here to talk about, well, it's difficult to fit any psychiatric topic into 15 minutes, but I've chosen 3. Why is it not? Why are the screens not moving? Okay, fine. But I've chosen 3 topics. One, screening for low mood. The second, referring patients to psychiatric liaison. And the third, tailing patients under Section 5.2 of the Mental Health Act. So I'm sure in your clinics you see a lot of patients with head and neck malignancies for whom life is getting quite stressful. And if stress gets too much, obviously that translates into low mood and depression. I wouldn't say that anyone is expecting an ENT specialist to do a full mental state and make recommendations about mood and start antidepressants, but what is very useful is implementing the PHQ-2 screening tool. So the PHQ-2 can be used to identify depressive disorder and identify those who may benefit from further assessment. It has a wide evidence base. It is an effective screening tool, but it's not a diagnostic test. So it comprises two components. So asking the patient whether they have little interest or pleasure in doing things, and whether they feel down, depressed, or hopeless. And each question is scored 0 to 3 as detailed on the slide. So 0, not at all; 1, several days over the last 2 weeks; 2, more than half the days over the last 2 weeks; 3, nearly every day of the last 2 weeks. So you add the 2 scores together for a total score of 0 to 6. A score of 0 to 2, depression is less likely, but greater than 3, that should prompt a more comprehensive assessment. So from your perspective, the most helpful thing to do is alert the GP to your concerns about the patient's mood in your letter, and perhaps alert your specialist nursing team if the patient is attached to that. I wouldn't expect an ENT specialist to do anything more than that, but it's good to be alive to those possibilities, and it's helpful in the holistic care of your patients. Okay, next slide. So we're moving on to referring to liaison psychiatry. Speaking anecdotally to friends working in various different specialties, medical and surgical, it can be difficult getting the attention of liaison psychiatry. One thing I would do is be as detailed as possible, because what you're creating is a legal and clinical record is why you think psychiatric input is necessary. Clinical detail protects the patient, the psychiatrist, and the surgeon, and a vague referral is not going to get the attention of the psychiatric team. So what to include in a referral? Any previous diagnoses, previous admissions to psychiatric units, any past suicide attempts or self-harm, past response to psychotropic medication, any forensic history if relevant. But of course, you must include details on the presenting complaint and what you're worried about at that moment in time. This is a busy slide, but it's basically about the mental state examination. The various components of the mental state examination are on the screen. So comment on appearance and behaviour, speech, mood and affect, thought, form and content. So any kind of paranoia, delusions, bizarre ideas, whether the patient's experiencing any disturbances of perception. So are they hearing voices? Are they having any visual phenomena, any kind of strange sensations in the body, any alterations in taste, and their cognition. So are they alert, confused, and you can use an ENTS if needed, but just a few words in that regard is helpful. And it matters because it helps the psychiatrist assess the urgency of what needs to be seen. So take-home points, past psychiatric histories are central. Mental state examination can be brief but must be specific. Be very clear about your concerns about risk, whether there's risk to self, risk to others, and make it clear and factual. This is about the patient at the end of the day. And if you're worried about any risk to themselves, and I can imagine in ENT, there's a lot of high lethality self-injury. So it's all the more important to be abundantly clear. And if you get knocked back, then reapproach them again if that ever happens. Okay, so just a bit more detail on risk. So risk can be divided into different aspects. So there's the risk of suicide. It doesn't increase a patient's risk to talk about suicidality. And it's really important to get an idea of what's going on in that regard, whether they're just having passive fleeting thoughts or whether they have a clear plan, clear intent, and the means. So do they have access to any toxic substances, any blades, any ropes, any firearms even. It's also important to talk about self-harm. Again, it doesn't increase risk of self-injury, but it gives you a better idea of what's going on for the patient. So any recent cutting, burning, head banging. And it may feel awkward, but do ask about aggression and violence, anything you've observed on the ward towards family or other patients, and what could be their triggers. I know that patients may not even know themselves, but it's important to qualify that risk. Anything to do with absconding, so are they intent on leaving the ward against medical advice? Are they pulling out their lines? And if you can, say something about vulnerability and exploitation. What have you observed on the ward? How they interact with other patients, how they interact with staff, and what do you know about any risk of vulnerability outside of the hospital environment? So this links us into detaining someone under 5.2 of the Mental Health Act. So 5.2 is a doctor's holding power, and it is a aspect of the Mental Health Act that enables a registered doctor to detain an informal patient who wishes to leave the ward where there are concerns about their mental health, and that when leaving would pose a risk to their health, their safety, or the safety of others. So detaining someone under 5.2, you can only detain someone already admitted into hospital. So you cannot detain someone in A&E under section 5.2, neither can you detain an outpatient or someone waiting in an ambulance under 5.2. So it buys you time up to 72 hours so that a Mental Health Act assessment under either section 2 or section 3 can be arranged. So implementing section 5.2. So it's really important that the doctor detaining someone under 5.2 of the Mental Health Act is a registered medical practitioner. So it can't be an F1. That said, by all means, take your F1 so that they can see what happens when someone is detained under 5.2, so that when they're an F2, it's not a surprise. If you are thinking about detaining someone under 5.2, and if you have time, call up Psychiatry and have a chat about it. It's really important to tell the patient that they are going to be detained to the ward and what their rights are in that moment in time. Thereafter, complete the paperwork, and I'll show you a slide coming. The next slide is the form. So once you've completed the paperwork, inform the hospital managers. Again, liaison psych can help you with that. It's also important to let the charge nurse know as well, so they can assist with that matter. It's really important that the examining doctor completes the paperwork. Don't get another doctor to examine, fill out the form, and then you just sign the bottom. Just think about if you ever have to talk about this detention in court, a judge wouldn't look very kindly upon someone who has taken an oath and has actually said, oh, sorry, yeah, it was my F2 that did the form and I just signed it. If you're going to detain someone, do the entire piece of work. So this is what the form looks like. It's a little bit blurry, but I'll take you through it. So the manager's name, put your full name, the address of where you work, and your work email. And you're either the registered medical practitioner or the approved clinician, or you're the nominee. So most of you will be the nominee. So you can delete A, and then you put the full name of the patient. And at the bottom of page 1 and over to page 2 is your reasons why you want to detain someone under section 5.2 of the Mental Health Act. And then you sign it and date it, and then you send it on to the hospital managers. And I can't change my screen. Sorry.
Please don't be sorry or wait. This is really useful information. It's so helpful to see a draft letter like.
I wish I'd had it years ago.
I just change the screen. Hang on. Oh my God, what's going on? Has that worked?
Yep.
I'm looking. So in the section at the bottom of page 1, going on to page 2, what you need to write is the patient's current mental state, what the risk of leaving involves, and why voluntary measures have failed. So you've completed the form, but document the same in the patient's medical and surgical notes as well. I don't know why it's not so strange.
It's genuinely no problem. We've got plenty of time because the other 2 talks are pre-recorded, so there won't be questions for them.
Okay.
And this is really helpful information, so please don't worry.
Okay, so in 15 minutes, we've gone through screening for low mood with the PHQ-2. We've talked about how to refer patients to psychiatric liaison, and linked to that is detaining someone under the 5.2 of the Mental Health Act. Apologies for the technical issues, but yeah, thanks for listening. I'm going to stop sharing my screen now and just go back to the Teams room.
Thank you so very much.
Does that work?
Yeah,
Okay.
that was perfect. That was so helpful. Loved the idea of the draft letter and things. Oh, and we've got some questions already.
By all means, yeah.
Yes, Anya Selwyn. Hi, friend.
Hello.
Hi.
That was brilliant, Rosie.
Thank you.
So the question I wanted to ask was, if you want to detain somebody under the 5.2, what do you actually say to them?
So I keep it very straightforward. I say, I understand you want to leave. These are the reasons that I'm worried about you leaving. So, for example, they've committed, there's been some quite serious self-injury. You've hurt yourself already quite badly, and the level of distress you have right now. I'm really worried that you're going to leave and hurt yourself again. For that reason, I'm detaining you under Section 5.2 of the Mental Health Act. This means you are detained to this ward for up to 72 hours. I'm going to contact Liaison Psychiatry so that we can arrange a formal assessment under the Mental Health Act. That will mean that you'll be seen by two psychiatrists who work independently of each other and an approved mental health professional. They will do a comprehensive assessment of your mental state to determine what your risks are and whether you need to stay in hospital.
Brilliant.
Something along those lines.
That's great.
So helpful.
Yeah. I don't know if there's any other questions or anything coming through in the chat. If people want to raise their hands or write any questions they have in the chat. But one of the things I wanted to know is that we see quite a lot of quite distressing trauma as medics.
I can imagine.
Yeah. And we've had some pretty horrific cases. What is there? I appreciate this is not your role, but I feel like this is something that you'll have expertise on. Is there any way that we can signpost maybe that some of the juniors that have been dealing with such distressing things? Do you know who we'd signpost to for them to talk to someone?
So I don't know what happens in your respective hospitals, but what happens in the Northwest is they have Schwartz rounds, which is a reflective group session where resident doctors, bring cases that they want to talk about, want to reflect on, and either get some greater understanding or get some closure. I know not everywhere does them, but Schwartz rounds do generally, if you don't have them, look into them, because they're there to provide a safe space where people can talk with their colleagues and someone who's done training, psychotherapeutic training, to enable them to sort of process what they're seeing. Because I've seen some neck self-injury, and it is the high potential lethality is terrifying, and it is very graphic. So yes, Schwartz rounds. Other than that, there's the BMA offers. Is it the BMA? The BMA offers 12 sessions of talking therapies.
PSU, I think, as well. Professional support unit, doesn't it?
Yeah. But having been through psychiatric training, I think it's really important that cohorts can sit together and reflect and
You've just gone mute for a second.
Yeah, it's very strange. But I'm very much for cohorts of trainees being mutually and reciprocally supportive with each other. So if you haven't got Schwartz rounds, look into getting them implemented locally.
That's really, really helpful. Thank you. Any
other
questions or anything before we let poor Dr. Arel go? Can't see anything in the chat. If there is anything, I will collate everything together and I will email you if that's all right.
No worries. Yeah, absolutely.
Thank you so very much.
Thanks for having me.
Yeah, no, it was so helpful. Yes.
Oh, yes. No worries. My absolute pleasure. Take care, guys. Thanks.
Thank you so much.
Bye-bye.
Oh, she was so fab. So we've got 2 now pre-recorded sessions. As apologies, people couldn't make it today. One of them we'll be able to share, but unfortunately, one of them there's some technical difficulties when we ran our technical check. So I'll try and upload it separately as a link. So we've got wonderful Dr. Taylor, who's our specialist in palliative care. And I will try and see if I can get her to work.
So during this session, I'm going to focus on a real life case I was involved with. It was about a year ago now. And I was involved over the course of the last few months of his life. He had several admissions to the acute hospital setting under ENT and then finally medicine right towards the end of his life. And the aim is really to apply some of the learning outcomes to this real life setting to hopefully increase an awareness of why these topics are important and the value of team working between our. So Mr. X was a 55-year-old gentleman who had had a previous medical history of a hypopharyngeal SCC. He'd undergone surgery followed by radical chemoradiotherapy. His treatment was unfortunately complicated by a persistent large tracheoesophageal fistula, and so all of his medications and feeding from that point had been via his rig, and that was back in about 2014, 2015. So not long after starting his...
Ooh. So apologies, I don't know if anyone else is having the same problems, but I think it may have gotten corrupted. I don't know if anyone would be kind enough to unmute and just tell me if they can see if that worked properly for them.
So no, me, Emma.
You can't see it.
No, we can't.
Well, I'm so very sorry. That's a technical issue on my side. So what I'll do is I'll look to try and see if I can upload that then as a separate YouTube link, and I'll send it all out to you. So sorry about that. And we'll get on top of this. So what we'll do then is we'll leave the meeting here for now. You can go and all enjoy the lovely sunny weather, and I will send you out a link once I've managed to make it work. Apologies. Thanks again.
Really grateful, Emma. Thank you so much for that.
Thank you.